Hi, everyone. Welcome. Welcome, welcome, welcome. Excellent. Wow, we've got lots of people coming in. Thank you so much, everyone, for joining us. We're going to get started in a minute. We had hoped for some welcome music. I couldn't get Zoom to do it, so you're going to have to just listen to me talking off into the void, each of you. But really, really wonderful to see so many people here. Excellent. Brilliant. Right, we've got 51 people already, which is just incredible. Feel free, everyone, shout out in the chat which organization you're from. It'd be really, really wonderful to see where everyone's kind of joining us from. Don't be shy, we don't bite. I won't pick on you. Oh, chat is closed. Interesting, thank you. Let's have a look at that. Okay, try that. That should hopefully have fixed that, everyone. Are you able to access the chat now? Yeah, awesome. Right, we're going to get started in just a minute. Yeah, awesome. There we go. The chat's working. Brilliant. Zoom has not failed us yet. This absolutely was user error. Oh, wow. Look at where everyone's coming in from. That's awesome. From all over the country. That's brilliant. Welcome, everyone. Oh, Joseph, good to see you. Excellent. Oh, Vic, brilliant. Simon, hi. Yeah, awesome. Welcome, welcome. Okay, we'll give it just another minute and then we're going to get started. Oh, excellent. Brilliant. Yeah, awesome. Look at how many people are here. Look at, we've got 60 attendants so far and we're coming from all parts today. That's really, really wonderful to see. Zara, excellent. Bernie, good to see you. Billy, come on through. Alrighty, I reckon we get started, hey? So we'll just start today just with an acknowledgement of country. So I'd like to start by respectfully acknowledging the Gadigal people who are the traditional owners and custodians on the land on which I'm calling on from today. And I'd also like to pay my respects to the traditional owners and custodians of the land on which each of you are calling in from today. Feel free to pop it in the chat as well. I'd like to pay my respects to elders past and present, and would also like to extend my respect to any Aboriginal or Torres Strait Islander people who are joining us on the call today. The sovereignty of these lands were never ceded, and they always were and always will be Aboriginal land. So, hello and welcome everyone to the first of our three-part webinar series called The Divergent Epidemic. And so the series really focuses on looking at multicultural communities' experiences of inequity within Australia's HIV response. And I think before we start, I kind of wanted to get us into the kind of mood by just asking a few kind of reflective questions and making a few kind of observations around the HIV epidemic and response in Australia. So when we think about Australia's HIV response, there's a series of many, many incredible achievements that all of us celebrate in. For me, and I think for a lot of people here, one of the greatest achievements that was the success of many of our community leaders in ensuring that Australia's HIV response was community-led. However, despite our many successes, people from culturally, linguistically, and ethnically diverse migrant and refugee backgrounds and LGBTQ people of colour are still experiencing the highest rates of new HIV diagnosis and late-stage HIV diagnosis within Australia, among many other health inequities. Unfortunately, Australia has a divergent HIV epidemic. And so when we think about that, when we reflect on that, a number of questions come up that I want us to think about as we go through the series. If communities are still experiencing disproportionate HIV diagnosis and conventional approaches aren't working, What are each of us here on the call today and across the response going to do differently? Who are we going to let guide the HIV response in Australia? And most importantly, I think, what steps can each of us take at every level of the response to ensure that people from culturally, linguistically, and ethnically diverse migrant and refugee backgrounds and LGBTQ people of colour are represented and leading every level of the response? A part of this reflection really requires us to consider and actually confront the issue of racism as a key driver for the divergent epidemic within Australia. This includes the impacts racism have on access to health services, information and advice. But we can also see this at play when we consider what data is collected, who interprets these data, and more importantly, what story is told and who is telling that story. We can see the impacts of racism when we think about whose voices are heard from in the conversation, who leads the conversation, and through the decision that those of us, myself included, in positions of power make that either bring us closer to community or farther away from community. So welcome again. For those of you who don't know me, my name is Harrison Sarasola and my pronouns are he, they, and I'm the team leader here at Health Equity Matters Australian Programs. I'm joined today by the incredible Justin Salerno, who's the Senior Project Coordinator, who's worked really, really hard to pull this event together in record time. So can we just start by giving Justin a little bit of love in the chat as well, because he's really pulled this together at no notice. And also to the panelists as well who join us as well. Before we start, I want to thank each of the members of Health Equity Matters Cold Network, without whom events like this just wouldn't be possible. Thank you for all of your continued guidance and support and for keeping us accountable as we move forward with these conversations. And I'd also like to take a moment to acknowledge the historic and ongoing contributions of people from culturally, linguistically, and ethnically diverse migrant and refugee backgrounds and LGBTQ people of colour to Australia's response, particularly Australia's HIV response, who often at great personal cost continue to fight for health equity. Thank you. And thanks also to each of you for attending the session today. There is a lot of work that needs to be done. It should have been done yesterday. It should have been done a while ago, a very long while ago, that we all need to do to make sure that Australia has an equitable HIV response. And so just by taking part today, you're taking an important step in helping us to all collectively achieve that outcome. And I know that all of you out there are already probably having these conversations and doing good work. So thank you also for all of your continued work and effort in this space. So now I'm going to stop talking and I'm going to introduce our speakers. But just before I introduce our speakers, just some quick housekeeping. So the session is being recorded. It's going to be available on Health Equity Matters website once the session is complete. Feel free, as you've already been doing, which I love to see, use the chat feature as we go throughout the presentation today. If you have a really specific question that you'd like to have answered by the panel, I'd encourage you to use the Q&A feature so that we know that that's a question that you want answered. We also don't have a physical microphone, but we do have a virtual microphone. So should you want to actually ask your question audibly to our panel, and we have the space and the time a little bit later on, please let us know in the chat and we'll try and let you ask the question yourself. So today we are joined by the incredible Dr. Corie Gray, Professor Amy Mullens and Dr. Kirstie Daken. Dr. Corie Gray is the project manager for the Community of Practice for Action on HIV and Mobility, COPAM for short, not FAM. I get this wrong all the time. It's COPAM. And Dr. Gray is also the acting project manager for the Sexual Health and Bloodborne Virus Applied Research and Evaluation Network, SIREN for short. As I mentioned, Dr. Gray is joined by Professor Amy Mullens and Dr. Kirstie Daken, who Dr. Gray will introduce in a moment. And today we're going to be talking about Australia's response to HIV and population mobility. So without further ado, Corie, I will hand over to you.
Thank you. All right, watch me seamlessly do the sharing of the screens. All right, is that looking all good at your end, Harrison?
Looking great.
Perfect. All right. Well, thank you, Harrison, for inviting me today. The doctor title is relatively new, so hence the celebration, and it's really exciting to hear it said out loud. Today's session, I'm going to be reflecting on Australia's response to HIV and population mobility, talking about through some of our successes, some of our gaps, and kind of most critically, the areas for action, particularly in the context of virtual elimination and what this means for a diverging epidemic. I would like to acknowledge my co-authors here, Associate Professor Gemma Crawford and Dr. Rowena Lobo. Before I begin, I would also like to acknowledge the traditional custodians of the land on which I'm located, the Whadjuk people of the Noongar Nations. The mosaic here in the background is from the floor of the Curtin Centre for Aboriginal Studies, and it celebrates diversity, community and knowledge. The mosaic was developed from an award-winning painting by the late Joan Martin, an Aboriginal artist from the Murchison area. It portrays the many different Aboriginal tribal groups coming together in celebration around a central meeting place. And in fact, this is a presentation about place, health, and people on the move. As such, I would like to also recognise the resilience and knowledge of those with lived experience of migration and of HIV, and the collective efforts of our service providers, policymakers, and researchers who are contributing to the shared aims of our HIV response. Before I get too far along, I do want to note I'm going to use a couple of different terms in this presentation: migrant, overseas born, people from culturally and linguistically diverse or CALD backgrounds. I recognise that these terms are problematic in a whole range of ways and look forward to our progress in better defining what and who we are talking about in a language that is meaningful to those we work with and for. And Ella's presentation will talk to this live issue with more nuance than what I will today. So why are we interested in the issue of HIV, migration and mobility? The team have spent the last 15 years looking at the impact of population mobility on Australian HIV notifications, and we recognise that mobility has been a driver since the start of the AIDS epidemic. We come to the issue from a health promotion perspective. We are particularly interested in the application and the translation of findings to our community organisations and service providers, and in participatory ways of working to achieve this, consistent with health promotion principles. Our thinking is also informed by Australia's population data. We are highly multicultural, but our approaches haven't always kept pace with our diversity, and we have had to become more knowledgeable over time. We have approached this issue by thinking about migration, about people on the move between countries. This has traditionally formed less of a focus in the HIV discourse, despite a compelling argument that migration and ethnicity is a critical social determinant of health and a structural driver of health inequity. So this webinar series has focused on the diverging epidemic, and here is one picture of WA's divergent, where a substantial number of notifications are required overseas. We recognise that the profile of HIV in Australia was changing. Our awareness was born from some specific changes that we saw in WA, but then mirrored in a number of other jurisdictions. In the beginning, at least in WA, this was about the increasing proportion of notifications amongst Australian-born heterosexual men acquiring HIV overseas, predominantly in countries like Thailand and Indonesia. And then it became about HIV notifications amongst people who were born overseas, predominantly women, and then people born in Asian regions, gay men acquired both in Australia and overseas after migration, with a substantial proportion diagnosed late. But actually, the data doesn't tell us the whole story in relation to population mobility. The International Organization for Migration suggests that health has been marginal in the mobility and migration discourse, in part due to the cross-cutting nature of health and migration issues and determinants. Conversely, we have seen that migration has been generally marginal. A limited understanding of the bidirectional relationship between migration and health has resulted in inadequate research, policy, and practice activities in the intersection between these domains. Our reflections are that we must pay closer attention to the drivers pre, during, and after migration. That impacts are complex, and they are not the same for each individual or community, with significant heterogeneity. There are significant impacts of transnationalism and intersectionality of living between two or more communities and countries, and that much of the information doesn't come from the data sources we already have. So, recognizing a change in the epi, but we had little to guide us in relation to social intervention or evaluation research around the practical on the ground strategies and responses required. We have a successful blueprint to work. We have a successful Australian blueprint to work from: power sharing, partnerships, involvement of affected groups. Our observation was that our previous successful approaches, these principles, were either not being applied effectively in these new contexts, or in fact, they were not effective. Some of the things that we have done previously requires continuation, but some of our strategies and approaches require tailoring to adequately address culture, religion, geography, cross-border cooperation, transnationalism, policy, racism, and significant heterogeneity. Meaning, meaningful participation also meant something different. Where were our populations? How do we access them? What would the consequences be for visas, for testing, for belonging, etc., of those engaging in the work? There is often a risk. And whose voices would be represented in our work? 10 years ago, with funding from the Commonwealth via La Trobe University's Australian Research Centre in Sex, Health and Society, we published this, the HIV and Mobility in Australia, a Roadmap for Action, which was what we knew at the time about HIV and population mobility, and presented 71 strategies or a roadmap towards action. We also established COPAM, the Community of Practice for Action on HIV and Mobility, with funding from the WA Department of Health as a vehicle to advocate to keep population mobility on the agenda in the local and national HIV response. Our activities included a national governance group, of which Professor Amy Mullens is involved in, a national network, advocacy activities, support for jurisdictional action on HIV and mobility, a website supporting students and broader research, publications, e-news, evidence updates, and professional development events. We like to keep ourselves very busy, it seems. Since the establishment of COPAM, the HIV sector has seen ongoing momentum to address strategies across policy, practice and research. And this has been documented in the 2015 and 16 interim report cards and a subsequent 2023 one. And in 2019, the HIV and Mobility in Australia Priority Actions document was released to further operationalise the Australian response to HIV and mobility. But there is more to do. So what does the research tell us? We know quite a bit about the barriers to accessing sexual health services for CALD populations, and research again and again paints a similar picture of the types of structural and social factors that limit engagement. Though I do note we need to avoid making generalizations about whole of CALD communities on this research. What we know less about is the enablers or the effective interventions. What works? Perhaps highlighting the need for a stronger policy practice research nexus, and highlighting a need for more action-orientated research and evaluation of existing interventions that I'm sure you're all involved in. Research has still been predominantly on communities rather than with, particularly in the broader migration space, but we do recognise that this has been shifting, particularly with the new terms around co-design and meaningful involvement. But it is a reminder to apply lessons we've learnt about meaningful engagement, inclusion, and strengths-based research. And finally, our focus has been on overseas born, and this has been driven by the Australian epidata, and less is known about cultural and linguistic diversity. So we have illustrated that there are some gaps. Our reflections are that there is no national data for CALD populations. We did have the Migrant Bloodborne Virus Survey in 2021, but unfortunately there is no ongoing funding for that project. We know that terminology is problematic and that this needs harmonisation both from a broader migration perspective as well as the HIV perspective. For example, country of birth, ethnicity, disaggregation of data by sexuality, overseas acquired, reason for travel, migration experience, pre, during, post-migration, visa status, different markers that capture the heterogeneity. There's a limited scale up of what works, and we need greater voice to research to policymakers from people within organisations who are doing this great work. We lack an understanding of the transnational health practices, and perhaps there has been a reluctance to look beyond kind of the Australian borders. Related, there has been an assumption around overseas acquired that these diagnoses aren't preventable, that infections occurring before arriving in that these infections are occurring before arriving in Australia. But certainly the WA data paints a different story. Migration is not a linear process, and people often frequently return to their country of birth or visit other countries on holidays. And we do have opportunities to reach people before they travel. But there's also been some great stuff. And this is by no means an exhaustive list. We've seen some increased publications and grants and collaborations across jurisdictions. There's been continued recognition in the strategy, but I note the loss of travellers in the recent ninth national strategy. There's been a commitment to enhance surveillance, and Ella will certainly talk more to this in one of the upcoming webinars. We have had the Migrant Sexual Health and Bloodborne Virus Survey. HEM is leading the CALDS affiliates network and doing some terrific work there. We've also got the multicultural health collaboration and the involvement of FECA. And there's some ongoing work of organisations like CEH, Multicultural HIV Hepatitis Service, PEACE and ECCQ. I also want to point out the fabulous Srakandi project, which is a participatory action research project that co-designed an intervention for HIV testing with women from Indonesia. And that originally came from Curtin as part of my PhD and now sits at WAC with the fabulous Karina. So where to from here for the sector? We need different types of data, centering the voices of people with lived experiences, service provider perspectives, people living with HIV. Local solutions require mechanisms which support meaningful involvement of affected communities, a cornerstone of the successful HIV response. This includes, for example, in leading data interpretation and acting on the data. However, there is a need to be thoughtful and reflective here. In the absence of nuanced data, whose voices are we capturing? Who are we proposing that they represent? And perhaps we're thinking about where we name people as communities, who might we be silencing? And is it totally fair to expect people with lived experience to solely carry this burden, understanding the potential risks that they may face? And while the craze of co-methods is welcomed, co-designed, co-created, co-evaluated, there are opportunities to look for ways of supporting people beyond just one-off projects and perhaps beyond HIV itself, and a move towards building community capacity through the use of community groups or coalitions, with a focus on the ability to self-govern and determine the agenda. And I'm sure Dewey and Jenny will talk to this more in the next webinar. We also need jurisdictional nuance and a national picture with a minimum data set. Sustained funding for a periodic survey could provide more regular jurisdictional data to inform policy and practice. We also need reforms for data variables that capture cultural diversity, supported by culturally appropriate evaluation indicators, and a mechanism for service providers to regularly and easily access, use, and share data stories, what works, what doesn't work. We need further granularity in data. When almost half of the population has a parent born overseas, who are we tailoring a CALD project for? We need data for and from scaled up interventions, such as broader projects that increase awareness of and access to PrEP. There are further opportunities for further rollout of HIV self-testing in community-based settings and campaigns that address HIV-related stigma. Ongoing advocacy on discrimination in migration policy for people living with HIV and those needing testing and treatment is critical. We also have an ongoing responsibility to regional citizenship. Our epidemic is not over until everyone gets to zero, particularly in light of current US politics and uncertainty in funding, as for example, the US President's emergency plan for AIDS relief and the World Health Organization itself. And there is a critical need for Australia and other countries to support and extend regional work, addressing the impacts of HIV across borders, including ensuring non-discriminatory laws and policies. For health equity for HEM members, this perhaps looks like sustained advocacy with international organisations, but perhaps also opportunities for collaboration and in situ resourcing. The research certainly suggests that people and information are not static, and transnational peer networks can play a powerful role in sharing resources, shaping attitudes and behaviours, and supporting access to appropriate healthcare, such as HIV testing. Australia's HIV response has always been political, and as our epidemic continues to diverge, we need a recommitment to a shared success for all, including people from CALD backgrounds, women, and First Nations people. This may require reconsidering and reimagining how funding is distributed, how we support other non-HIV organisations, and where perhaps control needs to be ceded. Finally, a note on the Australian aim for virtual elimination of HIV, or less than 91 new HIV notifications per year. At the tail end of HIV transmission, where microelimination has been achieved in some places and some populations, we need to think about who is or who will be left behind, underserved, or missed out in our agenda, and why this is. And so finally, what has this very small team been able to achieve? This is just a bit of a quick run through of some of the work that COPAM has been involved in. Here is a nice little infographic of some of the things that we've managed to achieve. This was at 8 years, we're now into 10 years. We also co-chair the International Student Sexual Health Network. We've got some further commentary there around HIV and mobility in Australia and overseas acquired. We have the roadmap, we have the interim report cards, the priority actions document. We also have a guide around developing culturally appropriate and effective HIV resource content as well. I do want to note that we sit over in the Odyssey, the Migration and Mobility Public Health Research Hub, which houses researchers from the Curtin School of Population Health, as well as those from other disciplines across organisations and institutions. And together as a group, we're investigating issues relating to public health, population mobility and migration, particularly in the Asia-Pacific region. And here are a couple of projects that you may be interested in, particularly this Kandi project. So that is all from me today. I would like to acknowledge again co-authors, Associate Professor Gemma Crawford and Dr. Rowana Lobo. If you want more information about the Community of Practice for Action on HIV and Mobility, you can look at the Odyssey research website there, and you can also connect with us over on LinkedIn. Thank you all. So without further ado, I am going to stop sharing and I am going to pass over to the wonderful Professor Amy Mullens and Dr. Kirstie Daken. Professor Mullens is one of the sits on the National Governance Group for the Community of Practice for Action on HIV and Mobility and has been involved in a COPAM HIV, COPAM at Queensland Queensland COPAM, I think is what I'm trying to say. So if I can pass over to you, Amy and Kirstie.
Thank you very much. Thank you, Dr. Gray. I appreciate that. I'll just share my slides. Okay, can everybody see that okay?
And Kirstie, can you go to the full screen view?
Yeah, not a problem at all.
And thank you, Corie, for that warm introduction and welcome.
Just trying to remember what full screen view is.
And just while does anyone have any questions? Just because I'm conscious, we also want this to be we really want to make sure that, this is a really good dialogue as well. Did anyone have any kind of questions or thoughts, around what areas of action that they might be able to apply within like the work that you're doing at the moment, or are you already doing it already? Oh yeah, I think we've just got, yep, presenter view, perfect, awesome.
Wonderful. Sorry, Harrison, did you want me to get started?
Yeah, go for it, go for it.
Wonderful. Yeah, lovely, thank you. So I'll be presenting the first few slides and then I'll swap over to Professor Amy Mullens. Okay, so thank you everyone. It's great to be here and be talking about this really important topic. But like we've said, I'm a researcher and a lecturer here at UniSQ. Amy is a professor here at UniSQ, but we're both also clinical psychologists, and Amy is a health psychologist as well. So looking forward to be able to talking to you today about our research, particularly exploring some of our key findings from mostly Queensland-based Australian studies that we've been working on for some time with our collaborators as well. So I'll get into it. So firstly, I also just want to acknowledge the First Nations people and their ongoing connection to country, lands and waterways, and also pay my respects to elders past and present. Okay, so on this slide, we've just got some of our collaborators from a lot of these projects. I think we may have a few of our co-authors here today as well, which is great to see, but it very much has been quite a team effort with these papers. Okay, moving along. So several of these projects were also funded as well. So I'd like to acknowledge the Queensland Health Sexual Health Research Fund grants, as well as HIV FQ, Gilead Sciences Inc., MIBS, as well as internal funding that's been obtained throughout some of the projects from UQ, particularly the HIV Professional Chair and Griffith University. Okay, so a little bit of an introduction to get started about our research that we'll be talking about today. So very much the focus of the 12 studies in particular, and there will be references at the end of this presentation as well, if you'd like to go and read some of them, or all of them. It's very much been a collaboration across a range of different contexts. So, and I'll just move, sorry, the viewer thing out of my way, there we go. So it's very much spanned across different contexts, including tertiary, community, and working in the healthcare context as well. And our topics have been quite a range, including sexual and reproductive health, HIV, and hepatitis B. So here we have for you as well some of our key terms throughout the research. So the first one being that health equity. So it's really important for us to be ensuring that we're researching, access for everybody to access health services and opportunities for all, particularly for our marginalised groups. And that's one of our key focuses for our research, working with marginalised populations. Of course, there's been a focus on HIV and migration, mobility, particularly around the travel patterns and influences and migration. And again, the key populations that we have been working with include university students, migrants, and youth from cold backgrounds. Okay, so I just want to start by talking about some of the key themes that have emerged from the research. So the first one has been around the different obstacles that I think Corie touched on as well for accessing healthcare across the different range of environments that we've been researching in. And we'll go into that in more detail in a moment as well. We've very much been looking at identifying the knowledge gaps in healthcare as well, from both a community and health professional level. So for some of our projects, we've really been looking at what are the views from our community members as well as from the health professionals. How might they differ? How might they be the same? How can we help bridge some of those gaps? And then the cultural and structural obstacles to positive health outcomes as well. And we'll go into those a bit more in a moment. Okay, so starting a bit then with the obstacles for accessing healthcare, particularly when it comes to sexual and reproductive health for this population. Language barriers has been a common theme that's emerged. Cultural stigma and discrimination. So it has come out as well, for example, in one of our studies that different communities would be looking to seek out health professionals that might be a part of their cultural community or background. But they might be concerned that there is stigma, or they might be concerned that that person might know them, or that it might get back to people they know. And so that might lead to them not accessing healthcare. Discrimination as well. The next one, misunderstandings, ignorance, and sometimes assumptions too. So there can be those concerns around health professionals not fully understanding that person's background or what they might need to be considering and looking out for them. There has also been that concern around the expectations where health professionals might assume that people from different communities have had particular tests or health services when that hasn't been the case. And then the individuals might assume that if it's important or something they need to think about, the health professional will raise it. So there's been some gaps in that area. Confidentiality concerns as well. Like I said before, particularly in different communities, that concern around if they are from their cultural background or community, what if it gets back to somebody they know, or that concern around what they might think of them. So for example, some of our studies have shown that university students face discrimination and stigma when seeking sexual and reproductive health services, and that can be quite a barrier for them. Immigrant groups may not perceive themselves as being at high risk for HIV due to cultural biases, and that can hinder their proactive healthcare seeking as well. Okay, so I'll hand over to Amy here. Thanks, Amy.
Thank you, Kirstie. And I just want to highlight that in relation to, I guess, the obstacles Kirstie alluded to earlier, it's equally important to look at facilitators and enablers. And in relation to our slide earlier around the definition of equity, just kind of re-emphasizing the importance of not necessarily equality, but trying to have ways for people to have similar opportunities to pursue health and well-being. So removing barriers, removing obstacles in order to do that. And then just one other point around terminology, just thinking about ignorance and that term I'm thinking about more as across society, and what we're seeing particularly with some of the global events that are silencing large groups and communities, and that wasn't intended to refer to people from diverse and heterogeneous cold communities themselves being ignorant. So just wanted to mention a few language things and to really recognize the tremendous contributions from our community partners and the co-led nature of this very large body of work that spanned over 10 years. And when Corie asked us to come along and present, it was sort of this challenge of how do we synthesize the so what piece across a decade of research and that many published papers, as well as, many other projects that are still in process, so that there are some takeaway points for everyone attending. So just with that in mind, just wanted to emphasize some of the nuances, but really the importance of making sure that we're not trying to adopt a one-size-fits-all approach, that it's important to develop what's known as cultural fitness, so the ability to adapt and respond to the individual needs of the people that we're supporting and working with, to be aware of potential trends, but not making broad sweeping assumptions, and to think about the myriad of factors that impact people's sense of self and identity, healthcare needs, protective factors, and risk factors. So it's important that responses are community-based and culturally relevant, and that doing so in a way that is aligned with community needs and values. And it's important to also be mindful of cultural beliefs that might help to enhance or be barriers to health protective behaviors, and to then work in with communities to dispel myths sensitively, and in doing so, increase health literacy and capacity and agency of communities themselves to respond. And that's where it's important to have embedded community leadership and for projects to be community-led, and to look at ways that bilingual cultural health workers can bridge the gaps between communities and health care providers. And we have a tremendous body of research having to do with HIV PrEP and with hepatitis B in specific cold communities, and the ways in which our bicultural community workers are a critical and essential part of enhancing health and well-being. And also to think about the additional challenges that subgroups within CALD communities experience. So we have a lot of work that's focusing specifically on CALD young people and the ways in which there can be quite a disconnect between their current health needs and what's considered culturally appropriate or taboo within their families and communities. And how can we find a way forward to promote communication and to help support young people in need in a more sex positive manner. Next slide. Thank you, Kirstie. And really the need for increased awareness and education, and doing so in a way that reduces stigma. And that's where community and peer-led approaches can help provide a sense of trust and communication and further bridge gaps between needs and effective health promotion. And also looking at other specific priority subgroups. So in particular, university students, how can universities themselves better support the needs of international students, and to create supportive, non-judgmental environments for promoting sexual health literacy and services. Next slide, please. The importance of ensuring that testing and prevention is tailored, that there's opportunities for services to be confidential, for there to be information in multiple languages and the appropriate use of interpreters, and to ensure that centers and services themselves are culturally appropriate, welcoming, that there's visibility in terms of staff, and that people can feel like they belong to the services that they're accessing. And looking at innovative ways to reach people who may have barriers to transport or access, and to bring services to the community through things like mobile clinics, point of care testing, and again, the ways in which bilingual cultural health workers can bridge gaps. And next slide, please, Kirstie. So when I'm thinking about this body of research as a whole, what we can start to do is look at how the recommendations flow down to different levels of the ecological model. So for community members themselves, for health professionals, for larger communities and priority subgroups, for healthcare services and systems, and whole of society. But this slide focuses on structural and societal influences and what we can do in this space, which really builds on what Corie was mentioning earlier. So thinking about how we can leverage credible evidence-based findings from within Australia to advocate for policy change, to advocate for additional funding for services, and to prioritize the needs of identified key priority populations. Also looking at how we can better integrate sexual health services within existing health contexts, like pre-travel health consultations, and within university health services. And also to think about how we can collectively work together to change and challenge norms that perpetuate stigma and perpetuate barriers to access, and work towards a more positive, inclusive narrative around the importance and need of especially our young people to access appropriate sexual health and supports and services. Next slide, please.
Sorry, Amy, just really quickly on that. I just wanted to kind of touch on that point. So, you know, we're talking about cultural safety and how to create cultural safety and ensuring that services are culturally safe. I think, you know, a really important point to make here is that cultural safety is also created instantly when you're working with or you're connecting with a peer who belongs to the community that you're from. So I think it's also one of the points of reflection that's good here, you know, within the HIV response is we need to kind of look to, you know, our teams look across the organization and across, you know, the response more broadly and say, do we, you know, do we have representation of community at every level of the response? Because that cultural safety can't just happen at a service, you know, frontline level, which it's really, really important that when community go to a service, they're able to access and connect in with a peer, you know, who's a peer along the lines of culture, ethnicity, lived experience of migration, etc. But also more broadly, when we're thinking structurally around, you know, the structural drivers of cultural safety, it's also about looking at where, you know, people of color and, you know, people who are culturally and ethnically and marginalized are situated within the response more broadly. I just wanted to kind of jump in at that point there. You know.
Oh, thank you, Harrison. And I couldn't agree more. And the importance of there being meaningful involvement of members of affected communities at every step in the process and response. And part of this being I think, a moral and ethical remit to ensure that we're building capacity within communities and future health professional workforce and future researcher workforce from the ground up and to build capacity that way, which then influences power and status and can help to meaningfully change the narrative in a more permanent and sustainable way. So thank you for raising that, Harrison. So it's also important for us to consider intersectional identities and the importance of social determinants of health and the ways in which these factors can impede people's ability to access services, and that instead of taking a blame the person or a deficits model, look at how we can create services and systems that better lend themselves to meeting people where they're at across the life continuum and across various elements of identity and intersectionality. Next slide, please. And so I will hand back over to Kirstie, but before I do that, I just want to wrap up by saying that really this is a large body of work exploring things like knowledge, attitudes, and practices, barriers, facilitators, and recommendations across a wide group of priority populations and contexts, including things like cultural care theory, cultural adaptation, health literacy, and doing that within a broad range of contexts and priority communities. So I'll hand back to Kirstie.
Thanks, Amy. Yeah, so just to summarize some of what Amy said as well, we've got our further recommendations here. So we recommend that there could be continued discussion regarding sexual health concerns, particularly for these key priority groups. And that could include things like migrant community centres, university campuses. It's recommended that HIV prevention and testing becomes standard medical care, standard medical part of their treatment, in terms of including it in routine health checkups or as part of the pre-travel consultations. It's really important as well to employ community-based health promotion strategies. So linking back to peer-led instruction and partnerships with local organisations within the community. And then finally, for health professionals, it's really important that it should enhance cultural competencies and fitness, cultural fitness, to more effectively support our whole community members and young people from these backgrounds to feel more comfortable in accessing sexual health services or facilities. And like Amy said, that more sex positive approach as well. Okay, so for the next 2 slides, we have our references, in case you'd like to read some of the projects and papers. And that's everything we have for today. So here's our contact details as well. Thanks, everyone.
So thank you so much. That was really wonderful. I'm really curious, so that we all stop chatting for the minute. Do we have any questions? I'm really interested what the audience thinks. You know, please, are there any questions that kind of popped up? Yes, Yvonne, we will absolutely send out the reference list at the end of this. Did anyone have any questions for our panelists? Don't be shy. Yes, Carlos. All right. What I'm going to do, I'm going to try and give you the ability to talk. Go for it. Carlos. You should be able to unmute. Great.
Can you hear me?
Wow, we can hear you.
Okay. My colleague has a question.
Hi everyone. Name's Emil. I'm from Living Positive Victoria. Hi Amy, miss you.
Hi, good to hear your voice.
Likewise. I guess my question is more on, particularly in this presentation, how called is defined in this context and how it differs to, like, say, migrant groups. And I guess, is there really a better term that could be used for it? Because it's something, for example, that us as an organization don't use anymore. I think for us, the feedback we got is, like, instead of us saying called and amalgamizing everyone, we just talk about which community group we're actually talking about and representing. And I guess, yeah, in this context, I want to know, yeah, why.
Yeah, and thank you, Carlos. And I do acknowledge the problematic nature of the term, and it was more hinging off of what Corie had mentioned in her presentation, which is why I didn't reiterate that it was meant to be encompassing a very heterogeneous group of different priority subgroups across studies. And when we had approached doing this presentation, Kirstie initially started going study by study and looking at, okay, this is the specific group and this was our findings, and this was the next specific group and our findings. And we were sort of in two minds, and I was thinking, well, I think what they want is somehow us to synthesize the findings over a large body of work in a large period of time, which then you don't get that granularity in terms of then what specific recommendations are important for specific aspects of specific groups. Like our hepatitis B work, for example, is around supporting and working in with Vietnamese and Chinese communities in Queensland. And our HIV PrEP study was primarily among migrants in Australia from sub-Saharan backgrounds. And then our research in the tertiary sector has a combination of, say, overseas-born students, but also who are now domestic students as well as international students. And yeah, so in order to get that level of then specificity, we would need to look at each study. And in all of the publications, we do acknowledge the problematic nature of the term and which groups each of the specific findings are meant to be for, and which communities supported that. So thank you for the question, Emil. I think extremely timely. And thank you, Harrison, for sharing the article as well.
Thank you.
Thanks. And I might jump in quickly as well, just to kind of add, I think, as CALD is problematic, but then there's also, I think we've used the word community a lot and made assumptions that people kind of within this CALD community are all kind of, have similarities, or they feel connected to each other, or they feel represented in that group. So I think there's kind of a number of challenges around, how we, the language that we use and how we describe. And I definitely welcome continued conversation around this.
Great, awesome. Thank you, Yvonne. That was wonderful. Oh, sorry, Emil. Sorry. Apologies. That was a really, really awesome point. And yeah, I've just also shared in the link an article that kind of explores the issue of like whether or not in public health in community health we need to retire the term cold. Ultimately, you know, from Health Equity Matters position, that would be something that would also need to be defined and determined by community. So really, really wonderful to get your contribution there on that. I'm going to go now to Daniel. So Daniel, I'll just let you be able to unmute. Did you want to ask a question? Hi, Daniel. Yeah, we can hear you.
Can you hear me?
Yeah, we can hear you. Go for
Oh,
it.
great, thank you. Just by way of introduction, Daniel was long involved in the early days of HIV before many of you were born, but more recently involved in the multicultural space. I was a senior advisor at the Federation of Ethnic Communities Councils of Australia until my position was made redundant a year ago. And in that capacity, started a new national peak called the Australian Multicultural Health Collaborative. And I'm still very much involved, and I'm also part of the HAM CALD affiliates group. So thank you. I'm afraid I was late into the discussion, so I may have missed all of it. But I think the discussion that I've observed has been fantastic. I agree totally with the term, the hesitation about the use of the word CALD. In fact, wrote an issues paper on deficits in CALD data across the country. There's so much going on in that space now that I'm proposing, working with the Kirby Institute, to have a national symposium on CALD data. Why do we need it? What do we want to know? How do we convey that to communities, and what use do we make of it? So hopefully that will happen. But I've also been pleased to note in a bit of the discussion I've heard that the focus in so many of the previous national strategies has been on the overseas born, totally ignoring the fact that there are people who strongly identified culturally who were born here, second, third generations. And I'm also struck in terms of the broader work I do in the health sphere of how important it is that this sector is leading the debate about a range of issues which impact not just in HIV, but across the whole health system for people. So with those congratulatory messages, I'll shut up. But no, thank you. I really appreciate your work.
Sorry, Daniel, did you have a question for the panelists?
Oh, sorry. It was relating again back to data, because we know that there are so many deficits in health data sets around the identification of people from culturally, linguistically, and I added the term ethnically diverse, although we don't ever discuss in Australia what that means, So it's curious for me, in all the work we do, how are we defining the population we're seeking to address? So was that a question? I think that was a question.
Yeah, thank you, Daniel. We'll just maybe take this note. I'm just conscious of time, sorry. So I might just quickly just go. Are there any other final questions from the audience? Okay, awesome. So what I'll do, I'm so sorry to rush us along. I'm just conscious of everyone's time. We are at 2:29, which means we've got a minute. So can I just ask one massive favor from everyone? Please just click on that link for me that I've just popped in the chat. That should reveal a evaluation form. Please fill that evaluation form out. It's completely anonymous. But what it will help us do is obviously not only reflect and evaluate the session itself, but also it's got some options in there to let us know what you want us to be talking about, in the future and for future webinars as well. Now, I will just say really quickly, please make sure that you come to the other 2 webinars. We've got an incredible lineup of other amazing panelists. But before we wrap up for today, can I just give a huge thank you to Corie, Amy, and Kirstie. Thank you all so much for the presentation today. And thank you again, everyone, for joining us. So we'll see you in the next webinar. All righty. Thanks, everyone. Okay.